Hello everyone. Today we are going to see about upper limb nerves. I will be focusing on axillary nerve, radial nerve, median nerve and ulnar nerve and also about brachial plexus. Let's start with axillary nerve. Axillary nerve originates from the C5-C6 nerve root. This is asked in USMLE exams and it is quite commonly asked in other MCQs also. So, and the axillary nerve primary innervation is the deltoid muscle. As you see, this is the deltoid muscle which is blurred a bit to distinguish it from the other muscles. The deltoid muscle from this diagram, it is clear that it originates from the left lateral part of the clavicle. And you should also know that its function is that it enables a shoulder abduction. But the first 15 degrees of shoulder abduction from 0 to 15 degrees is by supraspinatus, and then from 15 to 90 degrees is by the deltoid muscle, which is supplied by our axillary nerve. The axillary nerve palsy can happen when there is any damage or fracture to the surgical neck of the humerus. So once it has been once a palsy happens, then it will present with inability to abduct the arm. Sometimes in the vignette, it can they USMLE vignette they can also say like there is a flattened deltoid, or there is loss of sensation over the lateral upper arm or over the deltoid anywhere. That can also be a. So now we will be seeing about the median nerve. Median nerve will be innervating the lateral 3.5 fingers. So as you see here, median nerve is that. So for 1, 2 and 3, this is the median nerve which is innervating the lateral 3.5 fingers, which is clearly demarcated by this blue line. So as you see, it is supposed to control the thumb movements, isn't it? But it also controls the thumb abduction and opposition, and it is essential for the critical, it is a very critical for the precision grip. What you need to know is the thumb adduction is not controlled by the median nerve. I will be dealing with about this in detail in the ulnar nerve, because the thumb adduction is controlled by the ulnar nerve. One should also know that apart from lateral 3.5 fingers, this is the thenar pad and this is a lateral forearm which is also supplied by the median nerve. The If you are appearing for national board NBME exams, we should know that the palmar cutaneous branch of the median nerve is the one which is responsible for sensation over the thenar region. So there is a syndrome known as carpal tunnel syndrome, which is due to median nerve entrapment. So the median nerve is supposed to pass through the wrist in this way, and it supplies the lateral 3.5 fingers and the thenar region, isn't it? So when there is an entrapment of the median nerve in this area, in the carpal tunnel in this area, where there are carpal bones, then it is known as carpal tunnel syndrome. So we should not confuse carpal tunnel syndrome, cubital tunnel syndrome and Guyon canal syndrome. I will be dealing with all that in detail in the forthcoming slides. But as of now, the one which is associated with the carpal bones is the carpal tunnel syndrome. So obviously, when this median nerve is affected, it will result in paresthesias or numbness of the lateral hand and the thenar region, isn't it? It can occur due to many reasons. It can be either due to hypothyroidism, where there is glycosaminoglycan deposition over here, resulting in carpal tunnel syndrome, or it can be due to acromegaly, where there is growth of the tendons, thereby resulting in compression of this area, or it can also be because of pregnancy, where there is edema. It can also occur bilaterally in construction workers using jackhammer. So the next step in treating the carpal tunnel syndrome is they should be given wrist pads or splints or even steroid injections like triamcinolone injections into the carpal tunnel is also a very good cure. It can be diagnosed with electromyography. Either you study the muscle or the nerve to know what the problem is. So electromyography or nerve conduction studies are the next best step. Let's see about the ulnar nerve. Interosseous is the muscle which is responsible for causing adduction as well as abduction of the fingers. So the ulnar nerve is a nerve which supplies that interosseous muscle. Therefore, ulnar nerve controls the finger adduction as well as abduction via the interosseous muscles. This is the first point. The second one is that the thumb, the movement of the thumb, since thumb is present laterally, it is logical to think that all movements of the thumb are controlled by the median nerve. But the thumb adduction is controlled by the ulnar nerve. The rest of the movements are done by the median nerve only, except thumb adduction, which is by ulnar nerve. This function is utilized to test the ulnar nerve, whereby we use the Froment sign, where there is an inability to pinch paper between the thumb and the index finger. This is because when the ulnar nerve is damaged, then thumb adduction is not possible. Thereby, it is not possible to hold the paper between the thumb and the index finger. The second one which you need to know about this is that the distal compression. Previously, we saw about the carpal tunnel syndrome. When there is compression at the wrist, but when the ulnar nerve is affected, then that is known as the Guyon canal syndrome. So here there is distal compression of the wrist as well as the hand and not the forearm, and this is what is known as the Guyon canal syndrome. In cyclists, due to the handlebar compression, it will present as paresthesias or numbness of the fourth and the fifth fingers, as well as the hypothenar eminence over here. So that is the Guyon canal syndrome. And by now it's obvious that it innervates the medial 1.5 fingers. If you see here, this is a medial one and the other half of the fingers of the, as well as the median forearm. When the ulnar nerve is compressed at the elbow, then it is known as the cubital tunnel syndrome. Cubitus means elbow, isn't it? So any compression at the elbow is the cubital tunnel syndrome. What we need to know here is that patient will get paresthesias of the medial forearm as well as the hand. So previously in distal compression, we saw that they will be having paresthesias only in the hand and the wrist. But here they will be having a paresthesias of the medial forearm too, but the nerve which is affected is the ulnar nerve. So cubital tunnel syndrome and carpal tunnel syndrome are exactly two different, because cubital tunnel is at the elbow, carpal tunnel is at the carpal bones. Cubital tunnel will affect the ulnar nerve, carpal tunnel will affect the median nerve. Okay, so it should not be confused with the carpal tunnel syndrome. That is the point which I am trying to emphasize here. So if there is any proximal compression of the median forearm, wrist and the hand, it is the cubital tunnel syndrome. So what is the recommended treatment? Overnight elbow splint is the recommended treatment, and surgery is not the treatment at all. Coming to the radial nerve. Radial nerve is the main innervation of the finger, wrist and elbow extension. So the only keyword that I would request you to remember for radial nerve is extension. So what is the muscles that it innervates? Radial nerve innervates the best muscles. That is the brachioradialis, extensors, supinatus as well as the triceps, because they are the muscles which are involved mainly in extension. So, and the injury mechanism is that the mid shaft humerus fracture or the fracture at the radial groove will result in the radial nerve injury. So mostly it will be like a comminuted spiral fracture of the humerus, or in construction workers or in child abuse, where the spiral fractures are much more common. So that is what will be the mechanism. The most high yield point is that any injury to the radial nerve will result in uh, wrist drop as well as the pronated forearm. That is the picture which we need to imagine for a radial nerve injury. So these are the extensors, the triceps, which we need to associate with the radial nerve. What about the musculocutaneous nerve? Musculocutaneous nerve primary innervation is the biceps brachii. Biceps brachii, the primary innervation is the elbow flexion as well as the supination. So when we do elbow flexion, we have already supinated our forearm, and in addition to elbow flexion. So obviously when there is an injury, it results in decreased biceps function as well as weakness. There is one more aspect of musculocutaneous nerve, where it will provide a sensation to the lateral forearm region. So that is another one which we need to remember, along with providing function to the biceps brachii. So the musculocutaneous nerve will arise from C5, C6, C7 nerve roots. So hence when this is injured, it will result in weakened elbow flexion as well as lateral forearm numbness. So let me brief you about the how does these reflexes testing as well as neural level localization. So if you see about biceps reflex, what we saw, it is supplied by the musculocutaneous nerve. And the nerve root of the musculocutaneous nerve is C5, C6, C7, isn't it? So the weakening of C5, C6 per se will result in absent biceps reflex. But the triceps is supplied by the radial nerve, which is by C6, C7. So mainly C5, C6 is the one responsible for biceps, and C6, C7 is the one responsible for the triceps. So this will test the integrity of the radial nerve. So this is how the diagnostic value of their of the nerve roots play an important role. What about the brachial plexus? This is the brachial plexus, and the brachial plexus is the complex network of nerves. To remember the brachial plexus structure and organization, it is easier to when we associate it with the banyan tree. So the banyan tree first has the root, similar to brachial plexus also has the root. The second portion is the trunk, and the third portion that the banyan tree has is the branches, but here we call it as divisions. And finally it has the cords, and these are the cords too. And finally from the cords there are branches. Okay, so let's see. So these are the nerve roots C5, C6, C7, C8 and T1. So they will be forming trunks. So these are the trunks. There is an upper trunk, there is a middle trunk and there is a lower trunk. The trunk will be dividing into anterior division and a posterior division, an anterior and a posterior, as well as an anterior and a posterior division. I'm sorry, this is a posterior and this is the anterior division. All the three posterior divisions unite to form this cord, which is the posterior cord. The upper and the lower will form the lateral cord, and this forms the medial cord. So the cords will then give rise to branches. This is what we already saw previously. So what I need to tell you is that in this slide, the cords, that is the lateral, medial as well as the posterior cords, are in relative to the axillary artery. So what you should know is that the lateral cord is the one which will be supplying three nerves. Out of that, two are more important. One is the musculocutaneous nerve and the other one is the lateral root of the median nerve. But medial cord will be supplying five nerves. Out of that, four is more important. One is the median root of median nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, as well as the ulnar nerve. The posterior cord is responsible for five nerves, but out of that, two, if you remember, it is enough. One is the axillary and the other is the radial nerve. So understanding these relationships is very much definite for crucial diagnosis. With this, we have come to the overview of our upper limb nerves. So I have an announcement for you. I am starting my mentoring lessons for medical graduates and USMLE aspirants. If you like the way I teach and if you want to get mentored by me, you can go ahead and send me a message in the comments. Looking forward to see you succeed. Have a good day.